Hello everybody, my name is Ramos. I'm a neurologist currently doing a fellowship in demyelinating disease in the National Institute of Neurology at Neurosurgery of Mexico. I'm going to present you a very interesting case. This is a 16-year-old male with no history of illnesses or significant risk factors who developed two acute seizures and generalized tonic-closing seizures for which treatment with magnesium valproate was started by his general practitioner, achieving a good response. 2 weeks later, multiple neuropsychiatric symptoms were added to the clinical pictures insidiously. Soliloquies, restlessness, insomnia, suspicion, mystical relations dogs, visual and auditory hallucinations, sustaining and prolonged postures, periods, bizarre facial expression, memory problems, disorientation, judgment errors. Over a month, he was assessed by different doctors and treated with multiple drugs with no response. At the end, he developed a cluster of 5 seizures and in a 24 hours period of time, without recovering to its baseline state. For this reason, he was taken to the emergency room of the National Institute of Neurology in Mexico City. In the neurologic examination, the patient was catatonic with no response to stimuli, maintaining postures in a serious flexibility way, and echolalia and echopraxia was present. The catatonia rating scale was 4 points. So then we performed a lung puncture and an MRI to rule out an infectious meningoencephalitis, getting these results. Hypercellularity with mononuclear predominance and normal proteins levels in the cerebrospinal fluid. Negative PCR multiplex. In the MRI, we observed hyperintensity and thickening of cerebral cortex, predominantly in dorsolateral prefrontal cortex here, on the right hemisphere, and frontal medial cortex, orbitofrontal cortex, hippocampus, and insular cortex bilaterally. So, in accounting subacute evolution, seizures, neuropsychiatric symptoms, and catatonia, renal and infectious etiology, we made the diagnosis of autoimmune encephalitis and sent samples to test antineuronal antibodies against superficial antigens and started treatment with high-dose steroids during 5 days and 5 plasma exchanges. However, after 2 plasma exchanges, the patients started with fever, chills, myalgias, and malaise. Chest CT scan was performed due to the high suspicion of COVID-19 in the middle of the pandemic. This scan revealed a subpleural nodular ground glass opacity localized in medium lobe and a consolidation area in the left inferior lobe. On the coronal plane, subpleural and perihelial pulmonary consolidation in the right lung was observed. Then a nasal swab was made. The SARS-CoV-2 PCR was positive. After all, the patient was stable with no hypoxia, no respiratory distress, and only a mild thrombocytopenia was observed, and finally doing well. The plasma exchange had to be temporarily suspended due to this thrombocytopenia and restarted after recovery. After the last plasma exchange, he was awake, attentive and oriented with seizures, catatonia, neuropsychiatric symptoms, and was discharged to home after the first dose of rituximab. In conclusion, since by the way, anti-NMDAR antibody was positive in cerebrospinal fluid. In conclusion, since the beginning of the COVID-19 pandemic, some case report of Guillain-Barré syndrome and autoimmune encephalitis related to this virus has been appeared in the literature. At this time, the conclusion of definitive pathophysiological role of SARS-CoV-2 in neurological disease had been made. Due to the temporal coincidence of the 2 clinical events in these patients, anti-NMDA encephalitis and COVID-19, we suspect of pathophysiological drive of SARS-CoV-2 in multiple ways. The breakdown of immune tolerance due to hyperimmune activation typical of this pathogen. Invasion of central nervous system, neuronal damage, and inevitable spread. And finally, autoimmune activation leading to autoimmune encephalitis. Unfortunately, it was not possible to perform PCR for SARS-CoV-2 in cerebrospinal fluid to make a more conscious correlation. More studies are needed in patients with central nervous system inflammatory disease and SARS-CoV-2 infection to reveal the mechanisms underlying the coincidental disease. Thank you very much.